So the bit we haven't done is talk about a name. And my daughters came up with something.
Okay.
So they said, walk around the block.
That's genius.
So I think that's not too bad. Have you got a better suggestion? But I think I'm going to go with a...
Walk around the block.
Yeah, and that's fast enough for me now. It's just a walk around the block.
We need theme music.
Theme music, yeah.
Get your guitar out.
Yeah. That's a push. And singing? No. Can you think of any song you know that would be suitable for a regional anesthesia show? And it can't, apart from Comfortably Numb. Okay?
We'd love to hear it.
Yeah.
We'll get a contest, actually. Send in your best song.
Do you have to have a prize for a contest?
I guess so.
We'll think about that.
We'll think of, yeah.
We'll think about the golden tui or something like that. Who knows? So, this show is about choices. Choices. We try to make good choices. We try to make the right choices.
Doesn't always happen.
No. But if you had to pick one block for abdominal surgery, one peripheral block for abdominal surgery, what would that block be?
I'm going to have to say rectus sheath. Yeah, little dark horse there, right? You didn't see that coming.
I am a fan of the rectus sheath block. Yeah. Uh-huh.
I'll tell you what I like about it, if you're interested.
I can't get out. So I feel like the old guys in the balcony in the Muppet Show. We're nailed to the floor.
It's dead easy to do. Even obese patients, you can dial down the depth. You can see that beautiful rectus muscle and the posterior rectus sheath, giving you an endpoint and a target. But more importantly, once you're at the right spot, the local just travels where it ought to. So to me, that's the biggest disappointment with the challenge that I have with tap blocks. I feel like when the time comes and I'm actually in the correct plane, and it takes some time to get there,
mm-hmm.
I'm just not convinced that my local is going to spread out in a nice broad sheet as opposed to just creating a little bubble. There's tricks to get around that with traveling with the injection and that sort of thing. But I think a rectus sheath to me just opens up so nicely.
So one thing I like about it is if the local isn't traveling, I'll put my needle in, and halfway through the injection, I will translate the probe down towards the pelvis or up towards the xiphisternum. And with the rectus sheath block, I can actually see if the local has spread or not. Whereas with a tap block, you kind of can see. With an ESP, I've got no clue. Okay, I've got no idea if all the dermatome segments are covered.
I think we need a whole show on ESP blocks, maybe.
A show on the ESP block, and this is going to have
Stay
people
tuned.
Divided. It'll have pitchforks and torches for the
brands.
ESP show. I like that. Yeah. No, okay. ESP.
Now, do you do your rectus sheath transverse or with probe longitudinal?
I do it with probe longitudinal. When I know where the wound is going to be, or I'll do it after the wound's closure, I'll usually end up with an adult, usually 2 injections, and kids sometimes away with 1. And I end up going right behind the muscle. So I'm within the sheath of the rectus abdominis muscle, and I don't know if I understand the anatomy about the arcuate ligament and where the layers of fascia go, but I think with the rectus sheath block, if you put it just behind the muscle and separate the muscle from that fascia, it doesn't matter if you're above or below the arcuate ligament. The local very often will spread down below that, and it doesn't stop, which is something I was told you had to go injection above and injection below. Now, when you're doing it blind, you also had no idea where you were. I had a case of a hypogastric ilioinguinal block using the POP technique, and I managed to get a femoral nerve block. It was obviously too deep, and put it in the iliacus muscle. And the ambulatory surgery patient, the hernia repair, went home in crutches. And I heard another story. Somebody got the patient up, and broke the leg when they fell out of bed at an institution, so I'm lucky that we picked it up.
Yeah.
But so I think a lot of the folklore and legend about the rectus sheath block was from before ultrasound, and now it's very easy to see. And I start with an needle lateral to medial. Often it's been hey, the epidural's failed, or this was a rush abdominal case, and I'll try and say I'll do the block rather than let the surgical resident do the indiscriminate drive-by shooting with the local and subcutaneous fat. That's not going to work. I'd rather go and do the rectus sheath block and provide good quality analgesia, and even leave a catheter in there.
Yeah, I agree. It used to be much more of a rescue plan than a pre-planned technique, but more and more this is part of our planned set of blocks for for midline laparotomy. Man, I've had patients wake up and look at me and go, "No, I feel nothing."
Yeah,
and obviously you don't get the visceral pain, but multimodal is great for that.
They also placed by the surgeon rather than placed by us. Again, if the surgeon has the abdomen open and they peel it back and
sliding a catheter out,
that is another good technique. I think that's so much better than just the million needle sticks through the layers when the abdominal surgery is closed.
Yeah.
But so I think that is number one. I think the tap block. There's now enough papers. It looks like it works. Although some people have tried to prove that it works, like that study from Scandinavia, the one that I hate.
The jigsaw puzzle.
It looked like maps of states. There's Pennsylvania, there's Rhode Island, and they had a
lot of Florida.
There was no, generous symmetrical cutaneous distribution with the tap block, and that was frustrating, and it kind of mirrored sometimes my experience. Which was more frustrating was every that publication was like 160 pounds and had 6-pack abs, and I'm like, come on, man, my patients don't look like that. And I do, of course. I'm just hiding behind the shirt here, the baggy shirt. Yeah. But it was 30, 40 pounds ago. Never.
We're not taking our shirts off in this episode.
Yeah. No need to throw the children out of the room.
I agree. And that's getting on to sort of a broader topic of what makes a tap block work, or one of these abdominal fascial plane blocks work. Is it a somatic block that you're after of every single one of those spinal nerve fibers, T9, T10, T11, T12? Or do you get some sort of a sympathetic block from, a low enough concentration of local that's spread out in that plane, and you can touch them and say, yeah, I feel that, but no, my pain is okay.
Or is it just systemic absorption?
Or is it just
infusion?
Yeah, there's probably something to all of that. Yeah,
all of the above.
Yeah, I choose D.
Yeah.
How about you? What's your?
So we've got the Duke was famously a guy who still persists with the open prostatectomy.
Oh.
And for that incision and those patients, I found the tap block to be phenomenal. But of course, when you come up, I have to pick one block. I can't choose the tap because it's not going to be useful above the umbilicus unless I do the 4-injection technique. Now, I usually say that the good type of regional anesthesia is a good day when you get 2 injections instead of 1. But when it comes to 4 to cover the abdominal wall, and there's good evidence that works in a complete abdominal wall block with bilateral subcostal taps and bilateral posterior tap blocks. I get it.
It's a lot of work, man.
That's just a tough day at the office if you've got a quick surgeon. You're repeatedly doing that, and trying to do that teaching residents. That's why I am so follically challenged. So that is a tough day at the office.
I know you're going with this. You're going to say QL is your favorite.
So I which one?
4.
And 4? There's 4. There was one published today. Did you see the one today? Okay. So we're filming this in end of June, and in Anesthesia in the UK today, there was one published where they go up at it's a transmuscular QL, so the anterior QL, and the main selling feature of this block is it spreads everywhere. Okay, it's of course it's great for abdominal surgery. It spreads all the way up to the thoracic region. I can't say I'm convinced with that it spreads up the parietal gutter. But the new approach is to go at T12 and L1, and you put it basically
Right
behind
below.
the diaphragm, the fibre of the diaphragm, right beside the vertebrae. And it's like a sneaky side-in approach to the paravertebral. It's what they've described. Because where they are, they don't show the transverse process. They show a slide above, but not we actually see the transverse processes of the vertebrae. And I think this is like doing a T12 L1 paravertebral. It's where we've got to now, but they've put another name on it.
It was inevitable as we
Coke or Pepsi. so this is the fourth QL. This one is described today. The transmuscular QL, when I've had it work, it's worked well, but then it has been unreliable. I think what you miss.
You're doing it wrong.
Well, we were told that. We published a letter saying, we actually did a study in cadavers, and we put radiopaque dye in, put the block in with ultrasound. We put radiopaque dye in and actually looked at the dye spread in a cadaver with a CR, and you did get extensive spread of local anaesthetic, no doubt, but it didn't go to paravertebral gutter, and we were accused of doing it wrong. And I think I would say if you and I can't do it right after years and years and years, what does somebody who's what chance does the occasional practitioner have? If it's that specialised, that actually serves no purpose. And it's kind of like driving a Formula One car on the main street. It's not. It's just. Come on, missus, hurry up. It's just not going to. That's just not going to work out well for you. So.
All right. So what is it?
I've waffled a lot, haven't I? I've not picked one yet. Do I have to pick something different? So other options. What have I got left? ESP.
Okay.
Or paravertebral.
Okay.
And you know how I love my paravertebral nerve blocks.
Yeah.
It's that long-term love affair. It is love, me and the paravertebrals. So, Jack Shelley and folks in Pittsburgh do a lot of paravertebrals for abdominal surgery and done that very successfully, and instead of epidurals. It's got the same downside as an epidural, but would I feel happier doing an ESP and patients are all getting hepatic abdominal surgery? I don't know yet. I need to wait for evidence. It seems appealing. What I found out is the ESPs that work best for residents are the ones that aren't good at nasal visualization. When the resident puts it in a little bit too far, they might actually end up putting in some paravertebrally. And then probably real wax. Like, that's really good on that side. Not so good on the other side. So I've had variable success, and I think I want to wait for some more studies to come out to get prospective randomized controlled trials before I commit to that. And so I'm really darn boring, but can I do what you did, Jeff, and pick the rectus sheath block? I think it's a great block to learn. Yeah. I think it's going to work for lower and upper abdominal surgeries. And as wide as the rectus abdominis is, it'll actually cover a lot of laparoscopic ports. So you actually will get a lot of the ports, which are often just vaguely off centre. So very few laparoscopic ports are put in very lateral anymore, so it actually works pretty well for laparoscopic surgery as well. So I'm going for the rectus sheath block.
There you have it. 2 out of 2 North Carolinians choose rectus sheath blocks.
Yeah, and so if you'd pick one, let us know what it'd be. I'd be interested to hear and hear about people's successes. You don't need to wash your dirty linen. We need to hear about your favourites. Tell us about your successes with regional anaesthesia and abdominal surgery. And if you've got to pick one block, let us know. And any other suggestions for shows, please let us know. I said shows again. I'm embarrassed every time I say that. It's another video blog. Oh my God, this is just so disorganised. It's 2 guys sitting in a basement just chatting about regional anaesthesia. That's all it is. Okay. But thanks very much.